Dr. Minter, and this is another episode of Off the Cuff, where we talk about all things corrections, and we also talk about healthcare in general. So I'm going to take a couple of brief minutes to talk to you about medication adherence. And why do we care about medication adherence, and what is medication adherence? So for my doctorate project for East Carolina University a few years ago, I concentrated on what makes medication adherence. Why do patients take their medication, or why do they not take their medication, even more importantly? So there's a lot of factors into that, and we can't touch on all of them, but I can give you a brief overview as to why that happens, or why it doesn't happen. Medication adherence is defined generally as when a patient takes medication approximately 80% of the time. So about 5 out of 7 of the days. It's not every single day, but it's most of the day. It's not a hard and fast number, but it's a generally accepted number. So if you're taking your aspirin or whatever you have prescribed 20% of the time, a couple times a week, when it's supposed to be every day, then that is called non-adherence. So, which is a little bit newer term, and we used to call it non-compliant. Now we call it non-adherent. It's kind of semantics, but it just means that the patient is not adherent to the plan of care for the medication. So why does that happen? In corrections, it happens for quite a few reasons. One of the main reasons it happens is inmates or patients are not used to taking medications. They come in, they have uncontrolled hypertension, they don't fill their medications, or they don't go to a doctor, they don't have insurance, or it's just not important to them. And that's not saying it in a bad way, but they have to be vested. People have to be vested, not just inmates, but people have to be vested that they're going to get a return on what they're doing. So when you have, say, high blood pressure, if you take the medication, you don't get generally an immediate effect of taking the medication. Now, if you take morphine, you get an immediate effect. So people can be more adherent to, say, pain medication. That's not always true, but in terms of things that are a silent killer, like hypertension, heart disease, et cetera, or even diabetes, it's not immediately apparent as to why people need to take medication. Patients are prescribed medications in jails or prisons, and then they have the opportunity to take it, and they also have the right to refuse it. And they can refuse it every day unless it's court ordered, and those are usually mental health medications. So why else do inmates refuse medications? Well, sometimes they can't hear the medication person coming. They also can't hear, they say they can't hear what's going on. There's a lot of noise in the pod. They may not see the person if there's a visual impairment coming in. Additionally, there's different timelines in corrections where some people sleep during the day. This is not meant to be an excuse, but it's just a way of life. And people are eating at different times, and so they may sleep through the medication call. And also, if the medication is too many times a day, they may not want to get up, and that's also bears true for people on the outside, or on the street, as we call it. People in the community, if they have a medication that's 4 times a day, how often do they really take that? So, for example, when I was in my master's degree many years ago in my in NP school in University of Maryland, the professor gave us a test. Well, it was an exercise. So she said, take this bottle of M&Ms, take it home, and I want you to take an M&M 4 times a day for the next 7 days until you all come back to class. So everybody got the bottle of M&Ms. And so we came back in, and everybody said why they took it or how they took it or if they took it at all. And of course, there was one or two that took it exactly as directed, with meals, before they went to bed, whatever the bottle had said. Some people took it twice. Some people took it 3 times. And then there was me who didn't take it at all. And so she asked, why didn't you take it at all? I said, because I didn't need it. And I thought it was going to fail, and it actually was a pretty good point as to what happens on the outside. So in terms of how we look at medication adherence, we have to have some buy-in, as it's called, by the patient. The patient has to be bought into they need this medication. And where does that come in? How do we get that across to them? So that's education. So we have to explain to the patient why they need the medication, and hopefully they understand and follow up with that. So, for example, if they are not taking their high blood pressure medication, I could say, here's your current lab work. Your kidneys are starting to be affected. This is a normal kidney function. This is your kidney function. And this is what happens over the next, whatever, years, 5 years, 10 years, in terms of hypertension and how it affects the kidneys and the heart, et cetera, et cetera. And you hope by educating the patient that they will become more adherent and start taking care of themselves. Not all patients in corrections have a higher level of schooling. It's very variable, just like the outside, but they don't always have the opportunities that people have that are on the street. They may not have finished high school, may not have even finished middle school or grammar school. There may be a language barrier. So all those things have to be addressed. One of the things that I used to say when I worked in the community was, when I was explaining directions, was before I said, read this, I would say, can you read? Because the patient might be embarrassed and they would take the paper, but they actually could not read the instructions on the paper. So that's important. And I continue that through corrections, and I say, when I give them something in writing, which is not too often, I say, can you read? Okay. And most people, I'm not saying it sarcastically, I mean it from my heart, is can they actually read the paper? And most people don't take offense to that. So if they can read, and if they can read in English, or if they need a translator line, or if they need it in Spanish, all those things are barriers to medication adherence. So I have never been asked when I've gone to my primary care provider, when they ask me what my blood pressure has been, and I hand them the paper of what my blood pressure readings are, I've never been asked, am I taking the medications every day? But we should be asking patients, are we taking the medication? Because that is an important step in terms of, and question in determining what the next course is. Because the next question after that is, why aren't you taking the medication? Is there a side effect? Is it cost? Is it too often? Or they don't see the value in taking the medication because there's no immediate effect, as in hypertension, which is also known as the silent killer, because there generally is not any side effects until later on. So all these things have to be looked at. The other thing I look at for medication adherence is I look at fill dates. So what's a fill date? A fill date is when you look at a patient's pharmacy record and you look at to see whether the medication, whatever it is filled on the correct date, or is there a gap? For example, if a patient was prescribed aspirin on the 1st of January and it's good for 30 days, the next fill would be due in 30 days. If the aspirin or whatever is prescribed is not filled for 2 weeks after that or 2 months after that, the next question is why? Was the patient incarcerated? Was the patient in the hospital or another inpatient? Were they in a mental health unit? Why is there a gap? If the patient has been inpatient somewhere, then they probably don't have an up-to-date adherence by looking at an outpatient pharmacy record, because whatever facility they were in was giving them the medications while they were in the facility. So when they get out, they have more medication left over, so they're not going to fill it right away, because those 2 weeks or 2 months or however they've been somewhere else has been covered. So that's another important piece of information for medication adherence. It's really a puzzle that has to be put together. You have to look at how many refills they had, and also the other thing is the medication supposed to be continued? Now, if a medication stops, say 2 weeks ago, there's no saying that that medication needed to be continued. Now, high blood pressure medication usually is continued. Diabetic medication is usually continued, but sometimes they get changed, and that's why a certain medication stops. So you have to do what's called a med rec, which is called a medication reconciliation, as it's known. And you also have to talk to the patient saying, are you still taking this medication? Are you still taking this medication? Yes, but I had some left over, or I took it from my neighbor, or I was inpatient in the hospital for 2 weeks, et cetera, to determine whether that medication is still valid. So that is medication adherence in a nutshell. And this is Off the Cuff, and I am Dr. Minter, and we will see you next time.